Hi, everybody. Welcome to another episode of Hybrid Healing Hour. Today, we are going to be discussing visualizing vascular disease with Joe Ence. Hi, Joe. Welcome on.
Hello, salutations.
Yes. So I am super glad to have you on and talk about this topic and all the innovations out there. So why don't you go ahead and first start with introducing yourself to our audience and telling them a little bit about your background and how you got to where you are today.
I'd love to. Um, when I was a teenager, I broke my little sister's leg on the trampoline and we went to the hospital. Hospital was packed. They put us in a back room. And in that back room, there was some cool equipment. And they said, kid, don't touch that. And as soon as they left, I fired it up. And they have like live x-ray, fluoroscopy, just the coolest gizmos, ultrasound. You could see under the skin in real time. And that was amazing to me. So I didn't forget that. I got in trouble, but it was worth it. Totally worth it.
This
So,
doesn't surprise me.
right. I'm going through college and I want to be contribute to society. I get a bachelor's in finance and another bachelor's in marketing and I get a math. And like I didn't have the skills to pay the bills. So I graduated college and there was a guy who was trying to bring carotid intima-media thickness to market. He was doing the fen-phen heart valve with the ultrasound and the lawyers, and we were like a private contractor for that billion-dollar suit back in the 2000s. And he had mobile ultrasound. He figured out how to put the machine on a lift in a van and then drive to the doctor's office and knock it out, scan the patients. Um, so that business was ending, the lawsuit where we were doing scanning for lawyers. And we're like, what's next in medicine? And all the research studies, well, the FDA uses carotid intima-media thickness, which is looking at the artery with ultrasound. And I've got models because to explain it, there's a carotid artery, one on each side. And the FDA uses this to study the statin class of pharmaceuticals, which is a big business. Lipitor, Crestor, Rosuvastatin, there's tons of them. And this is the tool they use to measure effectiveness. When they take this, does the walls get thinner? Does the plaque go away? Does the plaque shrink? And nobody was doing it clinically. Like it was a great research tool, but hey, this handy information is pretty handy. Why are we not? Because it's a correlation to the heart. If you can see plaque in the neck, there's like a 90% chance a similar size, shape, and composition of a plaque would be in both. So yeah, like, why aren't we using this? It's just crazy. And we learned how to do it. I went and I met Helmut Fritz. He was a researcher at Loma Linda, and he showed me exactly how to measure this at the Sonosite headquarters. We were doing the employees there. And I got the software. Sweet, hook it up, tell some doctors about it, and I built my first report on a spreadsheet. I got the available data to kind of relay it to the patients. This is where you stand and compared to everybody else because you get a number, you don't know what it means. I need context. So I built a report that had more context. And I did that till the pandemic, and the pandemic hit, and we got to make a change. I had to update my ultrasound equipment. I had to, um, redesign the report, and it came to me in like one night. I wrote it all down. I still got my notebooks, all the cool drawings of the artery, like where the plaque is. And I hired an artist. I really got to understand the technology, the state of the art. You got the big machines, like this guy right here behind me. And then
Yep.
you've got
Yeah.
these small probes, which your clinic uses, which plug into a
Yep.
tablet. And anyways, it became much easier to deliver this report. Um, Now that the mobile's getting the technology's getting cheaper and better. Like my first ultrasound machine was $250,000, and now they're $5,000, and the
Yeah.
quality's even better. You can see to the resolution of fatty streaks in the artery, you can see plaques, and you can show it to the patient. So that's how I got to this point. And I'm going to show you my report here in a second. But enough be said that you guys, your clinic is now offering this, and patients can do it. They can see it, and we can do it in such a way that you can watch along with the ultrasound technician, and you can figure out what's going on. And like a couple weeks ago, I was scanning, and this guy was 50% blocked, and he's like, "Not too bad, huh?" I'm like, "Dude, This is not something to like lose sleep over, but something to, an objective
It's
to
not
go
too good
towards.
either.
Yeah, this
Right.
is not nothing.
Yeah, and you said earlier that we're not just looking for a carotid artery disease, we're looking for heart disease. We just happen to be looking at the artery that's in the neck. And you can correlate all your vasculature with coronary artery disease.
I mean, this helps assess the risk for cardiovascular disease. Yep.
Exactly.
And
And
like
if you're
early
improving,
signs, I'd say.
this will show you improving. Like if you made the right
Yep.
decisions and you're disciplined about it, but we can talk about sugar and seed oils.
Yep.
I'm going to skip past this one because you don't need that video. But so the measurement and tracking is cool, but showing it to a patient is where the money's at. This research study, they scanned a bunch of people. I think it was a few hundred. And they had a nurse afterwards say, hey, here's normal arteries, here's not normal arteries, and boom, here are your arteries. And after a year, the population of this study reduced their risk by 50%. And because they saw it, they understood it. We know what's killing us. We know what's being dangerous, Danios, what's the English word for that? Bad for our lives. And it's easy. So what we do is we look in the neck. We can see the lining very clearly, and we can see where it gets thicker there. Little fatty streaks are starting to form. There's layers to the wall. This is well understood. And there's even micro layers above this little green line, glycocalyx. And you guys, I know, are up on this. I'm super proud of you.
Yes.
I met you guys at a heart attack and stroke prevention conference. Like, you guys are in the know. I'm loving it. So here's a little bit of...
Yeah, if we want to prevent everything, and this is exactly what we want to do, is make everybody aware of how they can become aware of their situation and their status.
Yeah. I mean, we're all walking around thinking cholesterol is the end all be all, but is there junk in your trunk?
Right.
Is there plaque?
Right. And most people aren't even looking at the right cholesterol, right? So there's every piece of information we can get is going to benefit you in the long run.
Yeah, it is coming down to information, isn't it? You can make better decisions with better information. We map out where the plaque is, we show it to you, and then inflammation. So if the walls are thick, that's inflammation. If there's plaque forming, that's atherosclerosis. And inflammation is arteriosclerosis. How predictive is this? I could probably present this a little better, but 10,000 people over 10 years, the Caves Cafe study, and they classified them. Real bad chunky monkey, out of 10,000, there were 470 of them. Most people were fine, but the ones that had really bad arteries, in the next 10 years, 81% of them had a heart attack or stroke. If they had some chunky monkey, some plaques in the walls, some thickening, 40% of them, almost 40, 39, had an event in the next 10 years. But if their arteries were clean, almost 8,000 were that way, 0.13% had an event. And that, to me, seems like more of a electrical problem than a plumbing problem as far as what's causing that heart. But
possibly
your results are pretty, I mean, you'll know if you're at super high risk, and you'll know if you're at medium risk, and if you're at low risk, you can track it. Like, you can improve this and make it better over time. So we try to relate it to the patient in a way that's understandable. What is my vascular age? Let's say I'm 50 years old and my arteries are 70. Not good. 20, much better. And this is what the research studies use to track, meaning it will, if it just holds steady, that's considered a win, not getting thicker. Holding steady is a win. If you're getting thinner, man, you're on it. You're getting younger. That is hard to do. You got to cut out a lot of stuff from your life. And then plaque. Is there plaque there? We'll tell you. And if there is a plaque in your neck, pretty high chance it's in your heart. We'll show you.
Joe,
oh yeah, go ahead.
I have a question on that. So how often do you recommend that we check this on somebody? Like if somebody does it today and they see, there's some plaque and they want to see if there's any changes, do you recommend?
Okay, 6 months is aggressive. Year is about right, because this doesn't move quickly. You're remodeling your arteries. And then if they're fine and you want to check up every 5 years, that seems reasonable. But monthly, no, that's too much.
And how often do you see plaque regression?
Not as often as I'd like. I got some good stories about it that were not pharmaceutical based. There's foods, bergamot, natto. Nattokinase is the pill form of it. But I have never seen results with nattokinase. I have seen results with natto. And there's good research studies on natto. Like in a year, they opened up arteries 30%. I tried
So
duplicating it because I got some fatty streaks in my artery, but I could not.
a lot of patients know about coronary calcium scores, and coronary calcium score will not change, right? You won't see regression. In fact, the best you see is if you treat someone, their coronary calcium score gets worse. But with this, you can actually see improvement.
Yeah, exactly. If you treat someone with a statin, you will calcify the plaque, which is considered safe. However, there's those food studies showing that regression. I'm trying to track it down. I'm trying to reproduce it, but it's proving difficult.
I'm going to experiment myself with arterial, and because we know how the arterial works on the glycocalyx, like you said, and I'm not sure if you have a picture in this slide deck with the hairs, that we talk about that level right there. Yes. So like a healthy glycocalyx is the first picture with all the hairs. And then whenever we do have some atherosclerosis or plaque buildup, you start to have dwindled little fibers, and that allows more penetration to the wall.
Yep, and to explain to people, the glycocalyx is like a Teflon lining of the arteries. It protects the arteries.
Those little hairs are negatively charged, and they keep the blood moving along. And then it gets walked on like it's grass that's been walked on too much. And the arterosil is a derivative of a very specific seaweed, and it lays on top of that like grass, so the youngins can grow through. That's how I understand it.
Yep. Protection.
Oh,
Wonderful.
and actually, I can add to that conversation. So I think with ultrasound, I can see turbulence in the arteries. So red is going up to the brain. These little blue spots are back spinning eddies, right? So let's say you had too much insulin or sugar in your blood, and your blood becomes sandpapery or sticky, however you want to look at it. That rotation of the blood causes irritation, which wears down the glycocalyx. And so fortifying it with something like arterosil gives you a good shot at regrowing it. Because when this is gone, the bad cholesterol can push in there. The LP little A's, those bombing
Right.
in circles, and they hit, and the body just tries to fix it by sending in a white blood cell and gobbles it up. And that white blood cell will die and eventually turn into a fatty streak or a pus nugget or a pimple. We got loads of good names for them.
Right. Well, like you said, you mentioned LP little a. So we did a podcast on LP little a before, which I describe it as it has a tail on it, right? But that makes it extremely sticky, and that will likely, that increases your risk for heart disease if you have this mostly genetic modified.
It's more inflammatory and atherogenic. Right.
And so you might, I highly recommend anybody who has the LP little a to get this done, especially to get a good look. But it tends to happen a lot at that bifurcation where the carotid splits.
Exactly. That's the first place to look. Oh, you guys are on it. I love this.
So go back. Yeah, I don't want to throw you off on your slides. Go back because I love this discussion.
So the math physics of the vortices in the arteries, those eddies in the stream, it's well understood, but it's not really sold as a line. But hey, let's go back to LP little a little bit. When I'm scanning clinically, knocking out 30 patients a day, and I see a patient that has plaque on both sides, I will tell the doc, hey, be careful to look at their LP little a. I know you don't think you can manage it. You don't feel like you have a lot of levers to move it because it's a genetic problem, but there's some things you can do, right? What do you guys do for that?
Well, so we do clinical trials, and there are some new drugs coming down the pipeline in clinical trials that really significantly help LP little a. For people with severe heart disease already who have high LP little a, I mean, we even have apheresis, where it's almost like dialysis, where we can remove the LP little a from the blood. And that's a treatment that people have to undergo every 2 weeks, but it's well worth it for someone who already has significant heart disease. But then we use things like niacin, and then also the goal of LP little a is to try to get all the other risk factors down as low as you can. So we're just more aggressive with people with high Lp(a).
Right. And on those people, you know, that's a discussion we have about statin therapy. You know, statins right now are one of the better things we have, but out there is also Repatha, PCSK9 inhibitor, and Leqvio. They work differently, you know, so those are medications that have also known as inclisiran for the Leqvio, and they have been shown to somewhat reduce Lp(a).
I've seen incredible things on Repatha, but it's too good to be true to me, and I have to. I'm sitting back and watching how this game plays out.
I agree. I mean, Repatha and Leqvio both are phenomenal medications, and I think there's only even better ones on the horizon.
Yep.
You know, relative risk reduction for cardiovascular events. But no, and they're not statins, and people have like little to no side effects with both of those medications. So those I actually, I'm a fan of those.
There's even a new drug coming on the market in clinical trials now. That's a gene editing drug. It's one dose, one time and done.
What?
And it significantly lowers Lp(a). Yep.
Man, monkeying with the source code is becoming popular, huh?
It's true.
But you're right. I mean, the people who have Lp(a) will present differently, but even for the general population who, you know, don't know if they have that, at least getting a baseline CIMT carotid ultrasound to check the thickness would be a good look.
Yeah. This is one of the best ways to track it, and the patient seeing it and understanding it. I mean, if you want to engage your patients, I've found no better tool, because the story I've heard my whole career is I told them their cholesterol was bad, and they need a diet and exercise and cut out sugar and seed oils, and sugar's in everything. 150 pounds per American per year.
Yeah.
Our pancreas isn't designed for that. And they're going for it. They try to do better, and the patient doesn't improve. So the doctor on the next visit is like, you know, I'm sure you guys do this. You urge them, and if they're not willing, then on the third visit, you just give them a statin, because that's all you can do for that patient. They're not going to help themselves. How do you guys motivate patients in your art? I mean, you guys have really cool gizmos, great medicine. You're going to the right conferences. That's so nice.
We're real big on prevention, right? So we do a slew of blood tests. We don't look at just the typical cholesterol panel, right? So when we look at it as a multifactorial and alongside with genetics and lifestyle risk factors, right? So you have some people who exercise every day, they eat healthy, they're doing everything right, but then when their cholesterol is still high, you can basically tell they're not going to make a change with diet. There's nothing else they could do to improve their cholesterol. If they're not already doing everything, they're getting good sleep, their stress is down, they don't smoke, they don't drink alcohol, you know, so those people are the people, and I was actually just discussing this with him this morning, who don't have enough receptors to get rid of the cholesterol, right? So this is a genetic, mostly genetic risk factor there. And so that's where, you know, being on a medication like a low dose statin wouldn't necessarily be a bad idea to help give you more receptors, to help get rid of the cholesterol. Now, sometimes fiber really works for that too. Fiber can bind with the cholesterol and get rid of it. Even I'm blanking on the name of the orange powder that used to work really great.
Metamucil.
Not a fiber, but the medication. It's okay. We give it to people now, like if they have diarrhea, you can give it. It's a binding agent. They used to do it a lot back in the day, and it didn't really work well for cholesterol. But it would maybe work to just bind with the cholesterol to get rid of it.
So, you know, as much as I love the cardiologists that we work with, most of them are not preventive. And I really believe that it's all about prevention. So I rarely ever hear a cardiologist talking to their patients about seed oils. I almost never hear them talking about sugar in the diet, and you know, they'll talk about lifestyle, but it's generic lifestyle advice, right? Eat healthy, follow a Mediterranean diet, exercise. But we have to go deeper than that. We really have to start getting into the underlying causes of why we have so much inflammation, why we have so much metabolic syndrome, why we have so much insulin resistance.
Yeah. One thing I like about you guys is you're kind of like a doctor's office is kind of like food. If you want to find a good restaurant, you're looking for somebody who's a chef. They're proud of their food. They're passionate about it. They're always learning more, new techniques. Same thing with your doctor. You can get a doctor that's fed information by a pharma rep and they're punching a clock and they're seeing a patient every 10 minutes. Or you can find a artist who's learning new stuff and trying to bring it to their patient because they want to help. That's their calling. That's who you guys, that's your aura. Perfect. And there's just not enough docs that are looking and helping. But you guys are passionate about this and you're chasing it and you're bringing it to your patients and you're giving them options. I mean, the
Well, I
hyperbarics
think
you
there's,
guys were going to bring in was crazy.
oh yeah. So I think there's been a shift in medicine, and that's what I think you see this too, right, Joe? Like trying to, like you mentioned with this whole seed oils and sugar, right? I mean, we wear continuous glucose monitors sometimes to make people aware of what is happening. And, this is going to help with insulin resistance and metabolic syndrome, right? And so this is all what leads to heart disease. In our office, we do the InBody, which is a body composition analysis, and we check to see what their visceral fat level is, and yeah, we can put them on the whole GLP-1 medications right now, but not everybody wants that. So by just wearing a continuous glucose monitor and putting them on like a fasting diet or intermittent fasting protocol, which we discuss and we collaborate with them to set a schedule, they're able to make that change. And we're hoping then we can reduce their risk for cardiovascular disease overall.
Yeah, I did the glucose monitor with my daughter. I'm not a medically trained doctor. I'm real good at ultrasound, but I wanted to see how my sugars changed, and my daughter, we go through it and she's like, "Hey, I woke up and my blood sugar went up, but I didn't eat anything." Oh, that's your body homeostasis. Your liver released it. Okay. Right. And then you can see the wheels turning. And a few days later, she's eating more starches, trying to blunt a lot of that. And, a doctor is like a guide because we're running our bodies. Like, your guys aren't like the factory. You're not going to do a factory. Like, we got to keep this machine running good. And a good doctor will tell you, hey, sugar is poison. It's a drug. If you go off of it, you get headaches, you get the shakes. Like, it's not the best.
Yep.
Minimize sugar. And seed oils, they reduce testosterone. They have all these things on your gut they're not so great for. They killed the cows they fed it to in the 70s. And
Yeah.
the patient is going to make better decisions and you guys are the guides. And I think that's the shift in medicine.
And I'll be honest, I tell people all the time, I don't believe red meat is the bad guy. I don't think meat in general is bad. I eat red meat. I did experiment. I am the person who doesn't have enough receptors to clear out the cholesterol because I've experimented where I went mostly vegetarian, pescatarian, and my lipid levels did not change one bit. I still had high particles. So I know this is mostly genetic, and all I can do is just keep exercising a lot. And, I'm taking the Vascanox, the arterial, and, I'm taking some CoQ10, some supplements, that I want to try to reduce my risk overall. So I love experimenting with that. I want to actually dabble back to hear what your intake was on the natto versus the nattokinase.
The research studies said I took the nattokinase and I guess I just wasn't taking enough. I'm going to, because they're not really plaques, they're more fatty streaks, but I know where they are and I can track them. In fact, I got some pictures of them. I think I'll put them up like they're my kids. On the top left, these little bumps. Just gets a little bit thicker. That's not what I want. I mean, my arteries are like 21. I work pretty hard on not eating a lot of garbage. And the natto kinase plus serrapeptase, and there's a couple other enzymes, but serrapeptase is the enzyme the silkworm uses to gobble its way out of the cocoon. And that enzyme can break down calcium, no problemo, apparently. And then in concert with the nattokinase, it'll open up the artery. So I tried to take I took the kinase, the pill form, and I didn't get the results I wanted. Not that I'm going to get huge results, but so I started taking the natto. What was that?
How long did you take it for?
About 6 months.
Okay.
Then I reread the research studies because I wasn't getting the results. And then the research studies said, oh, you got to eat the raw stuff, fermented soybean, which is snotty. it strings out like hair,
Yeah.
like angel hair. You
I
can't
don't
get a
think I could
clean
do
bite.
it.
You get these cotton candy whispers all over, and it's sticky and it smells. And the Japanese put mustard with it when they eat it for breakfast. Like, this is not my normal palate. And I tried taking that for 3 months, and every day I'd stare at it for hours, just trying to get the will to eat it.
Trying to get the mentality of it, right? Saying, okay,
So
I have to do this.
I think my actions tell me that I'd rather die than eat it, but I got to give it another effort.
Interesting. Yeah.
But
I
yeah, the
mean,
research, you need 10 grams a day, which is a good fistful of it. And the Japanese sell it
that's a lot.
at Japanese food delis, food stores. Comes in little styrofoam. A lot of people make their own, ferment their own, rot their own. It smells like a bucket of wheat that's been left in a barn too long. A wet bucket of wheat.
Sounds terrible.
But you won't hear about this because there's no pharmaceutical
Right.
marketing engine behind it.
That's the problem with Western medicine. It's all money driven to get the clinical trials to look at these things.
And, I'm interested in doing some more research too. I know like BPC 157 is an all natural peptide. Now, I know it's different, but so it has been shown to help reduce DVTs and blood clots. So I kind of have seen it, I guess, eliminate a blood clot. But that person's also on a blood thinner and whatnot. And so, but it's an anti-inflammatory, and I feel like it would help reduce inflammation, and therefore it may work. But I can't say that it is the end all be all by any means. But then another one, Xarelto is a medication. It's a blood thinning medication, but it is FDA approved at low dose of 2.5 milligrams with a baby aspirin to help with peripheral vascular disease, which is in the arteries, peripheral arterial disease specifically. And so I wonder if, do I really want to be on that for prevention? No, but I just, think about that too. Would that help reduce and prevent? There's no data out there for that. It's more for the treatment of. So I'm always thinking about things.
You're on the cutting edge. Like, that's what I like about you. You're passionate about this. It's not homework to you. It's I can make people's lives better by reading about this. And
Absolutely.
the peptides, that whole market exploded, and I can't track it.
Right. I mean, I would love to find another peptide that I'm sure there are several out there that actually are good for vasculature. So I would have to see if there's any actual literature on the atherosclerosis or development of.
Yeah. Yeah. Hey, can I tell you a story that I saw over my career that kind of
Yes.
bugged me? So
Please do.
niacin has been known for a long time to have incredible health benefits. And when I kind of started this business, it was working with the niacin reps, the pharmacy. There was a company called Coast Pharmaceuticals. They're out of business now, I think. But they had a patent on an extended release niacin pill. And it's a great idea, good job. And they had wonderful reps, and they had decades of research behind them. Because niacin, short acting, regular, everybody knew it was great, but long acting was great for people who had issues. Anyways, they are crushing it. They're teaching, they're preaching. They got heart attack and stroke doctors going around the country. Here's how you start a program. This is what mine is. Baldonine is a great one for education. They just have a great heart attack and stroke prevention. Anyways, 2010, 2015, they lose their patent somewhere in there. Their marketing team is disbanded. And there's nobody like proclaiming niacin for your patients, like nobody. And the statin reps kind of came in and said, hey, it's not so great for diabetics and these other situations. Why don't you just use a statin? It's much safer. And statins do have a place, and in that last 10 years, it's just almost totally disappeared, except from the hardcore doctors. And I know that when a cardiologist has a heart attack or stroke, he will take 3 grams of niacin a day, which is not a comfortable drug to take. It's a vitamin, but it's difficult. But it has
because of the flushing.
Yeah, the flushing.
Yeah, if people out there don't know that, you can get significant flushing and feel like, for women out there, it'll feel like a significant hot flash. Yeah, and you kind of feel this warmth and heat come over you, and you can literally look red.
Yeah, you can take an aspirin to help mitigate it. It should help. But the flushing is how you know it's working. It's opening and closing
Absolutely.
vessels. It's the body working it through. And it's just so disappointing to me that the truth is niacin's good for you. It's cheap, it's effective, but nobody's pitching it. So any doctor who's graduated in the last 10 years, unless they're really passionate, they're just going to write what they're habitually told to write.
Right. I mean, we are definitely still fans of niacin,
Yes.
not just for heart disease, but it's been shown to be helpful with chronic kidney disease. There's just still many benefits of it that I think that it's a shame that it's not being talked about anymore.
Right. Right. And so I'm a lot more jaded in my view of mainstream medicine. And I'm
Right.
finding a lot of docs with great ideas out there. I'm loving it. And you guys, you're chasing the truth and you're delivering it to patients, which I don't think there's a higher calling. Maybe farming. Farming is up there. But helping people is awesome.
Well, Joe, I think this has been such a fun time talking with
Yep.
you. I love your stories. I always love meeting with you. So is there anything else you could tell our audience, like a take home that you want them to, the one thing to take home from this podcast?
Yeah. I studied the blue zones, where people live to be over 100. And they're all over the world. They're little pockets, Japan, Mediterranean. And there's 3 things you need to live long and healthy. One is to serve and be of service from others. I mean, don't be too much or you can't receive service from other people. That's part of it. People that retire and their purpose is gone, they die a week later. Also, they cultivate a good diet that's varied, not a lot of sugar, local food, fish, a lot of fermented food. The whole Italian antipasti. Like, if you want to eat better, start exploring like old school cultural, because anything your grandfather ate is probably okay. And then exercise, keep your body moving. And those 3 things, you're going to live a good long time. And that was like as simple as I could make it. The tools, the pharmaceuticals, like we need that now just because there's things like taquitos in the world. What science monstrosity is that? That's delicious. It's true.
And they're made with canola oil, right?
Oh yeah. Oh yeah.
And
like
red dye.
Yeah. Those seed oils reduce testosterone 40% in the American population. 40%.
Sugar reduces, sugar alone. I think 75 grams of sugar reduces the male testosterone by 100 points. So,
wow.
And think about 75 grams of sugar is like a soda and a cookie for the day. Like a can of soda and a cookie. I mean, I'm sure there's several people out there who eat that almost on a regular basis.
Oh my gosh. Yeah, that sneaks right into your diet.
Right?
Yeah. So to live long, it's to serve, be served, exercise, and eat great food, old school food, which I think is wonderful. But one more thing. You were talking about diets, and I just wanted to say that paleo meat heavy diets and vegan, vegetarian, they're both successful, but what they both cut out is Twinkies, corn syrup, sugar, white bread. Like that's not real food. That's candy food. That's cake. That's not nutrition. And so
I agree.
I don't care what diet you go on, but just be aware sugar is a drug. There's nothing not a drug about it. You're going to get headaches when you come off of it. And if you can get your body to run in keto mode, I think I feel my best at that. But you got to explore. You got to be sensitive to your body. You can't dance if you don't hear the music. Listen to your body and ride the waves.
I love it. You couldn't have said any better. Thank you, Joe, so much for coming on.
Thank you, everybody. It's good seeing you.
Thanks.
Bye.
Bye.
That was great. Thank you.
Yeah.
Yeah, that was rocking. That was fun.
Yeah. So what do you want to talk about when we come on yours? Is it next Monday? Is that it?
I think so.
Okay. You can always text me.
I will text you. I like